Okay.
Hello, my name's Rhian Tomas. I'm a GP in Holton, CCG, where I'm the cancer lead and also a Macmillan GP. And I've been asked just to give this presentation about safety netting. And it's been developed with support from Cancer Research UK and the Cheshire and Merseyside Cancer Alliance. So what we'll cover in these 12 slides is what is safety netting, why is it important, what guidance is there around safety netting, and what resources are available to support practices and primary care networks with safety netting. So in order to answer that first question of what is safety netting, just go through a bit of an overview of what the published work around safety netting is. So in 2018, McRae published this paper called When No News is Bad News, Communication Failures and the Hidden Assumptions that Threaten Safety. And they found that the long-term value of reliability enhancing practices such as safety netting is not always easy to see, whilst the short-term costs are highly visible, such as time taken for backup checks and maybe duplication of systems. Nicholson et al. In 2016 looked at whether safety netting can improve cancer detection in patients with vague symptoms. And they found that it certainly is important to involve patients and that this can help. However, it can be associated with longer delays in diagnosis and therefore reinforces the importance of safety netting and clarity with patients. This 2017 paper, which looked at emergency presentations, concluded that although in some cases emergency presentation of new cancer diagnosis can represent effective care, in lots of cases there have been missed opportunities or maybe prolonged referral pathways which have led to the emergency presentation, and that safety netting can help reduce those missed opportunities. In 2018, there's published work looking at the acceptability of text messaging for safety netting in patients with low-risk cancer symptoms. And they concluded that texts were acceptable and can be beneficial, but there was that need to ensure that they are confidential, cost-effective and user-friendly. And this is probably something that we've made steps towards during different working practices in the pandemic. And finally, Evans et al. In 2018 did a qualitative study of GPs' understanding and practice of safety netting for potential cancer symptom presentation and found that clearer guidance for practices would be beneficial. They also concluded that practice systems that enable active follow-up of patients with low risk but not no risk symptoms, which could represent malignancies, can reduce delays in cancer diagnosis without increasing GP workload. And I think the quote that's currently on the screen from a GP saying that safety netting is a word I use almost every day, but what does it actually mean is key here, really. So we know from those studies and the references below that current understanding and practice of safety netting varies widely within primary care. Safety netting was a term introduced by Roger Neighbour, and he had the three key questions. Firstly, if I'm right, what would I expect to happen? Secondly, how will I know if I'm wrong? And thirdly, what would I do then? And the third bullet point here gives another definition of safety netting. So a diagnostic management strategy that ensures patients are monitored throughout the diagnostic process until their symptoms or signs are explained and results have been acted upon. So I think that shows that it's so much more than maybe just encouraging a patient to attend an appointment or checking when result comes back. It's a whole strategy that has to encompass all of those points. So what might cause delay in diagnosis and why is safety netting important to this? So on this slide, we've got the whole process from patient first experiencing a symptom, that could be cancer to receiving a diagnosis and ultimately treatment. And within that, we have multiple and often overlapping intervals, and delay can occur at any stage during this. For the purposes of this presentation, we're going to be focusing on the primary care interval, but we can see there that that overlaps with other intervals, and that also we in primary care have a role to play in some of those other intervals, for example, in encouraging the patient to have the knowledge and ability to recognise early symptoms that could potentially be cancer and have access to first presentation with a clinician. I think we can probably all think of examples where at points during this process things maybe haven't gone as smoothly for a patient as we think they could have done. And it might be worth reflecting on whether those cases have been reviewed as learning points, whether significant event analysis have been carried out, or shared learning that has been within a practice or wider if appropriate. And do you have access to the information that you need in order to assess those cases? And if not, do you know where you would access that and how to access further support with that? So in terms of what the guidance is around safety netting, it forms a key part of the NG12 guidance for suspected cancer recognition and referral. So I've quoted directly there from the NICE suspected cancer guidance. But to summarise, the elements that specifically mentioned are ensuring that results of investigations are reviewed and acted upon by the requesting healthcare professional or by explicitly passing on responsibility for this. It also makes reference there to being aware of the possibility of false negative results, and therefore a negative test not being the end of the process for a patient who maybe still has ongoing symptoms. And that links in with the second point there, which is considering a review for people with any symptom that's associated with an increased risk of cancer, but who do not currently meet the criteria for referral or other investigation. That review might be planned and clinician initiated within a set time frame that's been agreed, or it might be patient initiated, but in that case it needs to be clear when and how that would be done, which new symptoms the patient should look out for, and any other specific features and timescales around that. Another element of guidance around safety netting comes from this 2011 report and introduces 3 elements of safety netting: patient communication, GP consultation and practice systems. And we'll elaborate on these 3 elements over the next 3 slides. So the first element of patient communication, that would include factors such as communication of expected timeframes that symptoms would be expected to resolve within. For example, making sure a patient knows how long to expect this hopefully self-limiting sore throat to go on for. And then the next step of how and when to reconsult if those symptoms don't behave as expected and don't resolve in the expected time frame. You'd also want to include within that communication specific warning signs and symptoms to look out for. So in this case, maybe hoarse voice or weight loss that might influence earlier reconsultation. There should also be a clear explanation of reasons for any investigations that are going to be carried out, and also how to obtain the results of those investigations. And within all of this, there's a need to consider any additional requirements to aid communication for that individual patient. So whether that's alternative formats of written information or using translators or any other individually tailored communication needs. Second element within the GP consultation, so that needs to include ensuring the patient understands the advice that's been given. And a key part of that would be taking any of those additional measures we've discussed there that are needed to overcome any communication barriers. There's also the need to make sure safety netting advice is documented in the medical notes so that it forms a part of the medical records and is therefore visible and can be referred back to and forms that part of the medical notes there. Highlighting again here, referral if repeated consultations for the same symptom. I think this demonstrates why it's so important to have clearly documented symptoms and, where possible, using standardised codes for these so that it is easier to see if the patient is presenting with repeated features that may all add up to cause more concern. Same for the next point, which is around further investigations if those symptoms are ongoing. And finally that need to keep up to date with guidance for suspected cancer so that we can make sure that the patient is having the most up-to-date information given to them at that GP consultation, and that we've got the appropriate clinical threshold for further investigation or referral. Within practice systems, we need to look at what would happen if results of investigations that have been requested didn't come back. Is there a system for highlighting this and taking action about it? Are there systems in place to ensure that contact details are up to date so that we know that we can contact patients if need be, and also that we're passing on the correct details for any investigations or referrals? How are abnormal results communicated to patients? And following on from that, is there a system in place for patients with abnormal results who then fail to attend any follow-up that's been planned for them? Are there systems in place to cover tests ordered by locums or for other clinicians' annual leave or unexpected leave? And are these systems documented? Are there systems in place to ensure that if results are acted upon, that's documented within the system and visible as part of the clinical records? And are standardised codes used so that things can be searched for and done in a systematic manner? And are SEAs or learning reviews carried out for delayed diagnoses within the practice or at the appropriate scale? And is there any annual audit of new diagnosis of cancers in order to identify any system gaps or further educational needs? So, reflecting back on that guidance, if we were setting up a new safety netting system within a practice or a primary care network, what would that system need to ensure that it's safe and robust? So we've just gone through a list here of some of the requirements to consider. So is the system universal and consistent? So can it meet all of the needs that we've just discussed? Would it be able to identify abnormal investigation results, or a patient that hasn't attended for a suspected cancer investigation, as well as maybe those that are on a suspend list with the hospital due to the pandemic? Is the system IT-based and GDPR compliant rather than being paper-based? So ensuring that it's fit for purpose, especially with increased remote working, and that it needs to be an IT-based system. Does it include daily checks and searches so that any abnormal results or failure to attend can be actioned in a timely manner? Is the system team-based and not dependent on just one individual so that it can be robust and isn't influenced by annual leave or unexpected leave for other reasons? Is the system linked in with the clinical system and using standardised codes so that it is accessible to all within the system, and if needs be can be scaled across areas if there are close clinical working? Does it cover both 2-week rule referrals and investigation for suspected cancer, and not just one or the other? Does the safety netting system include processes that can and will be updated to reflect any future changes in pathways? So, for example, if a new test is made available for suspected cancer directly to primary care, will that be added to the list of searches that are run? And is there standardised coding that will be used for that? And finally, does the system demonstrate that safety netting has taken place with the patient? So is it standardising the way that that's going to be documented within the records? So I'll go on now to talk about some of the resources that are available, but there is a safety netting toolkit that has been developed with support from Cancer Research UK and will be available on the Cancer Alliance resource webpage that we'll talk about, and that includes templates and searches that are designed to meet all of these requirements. So in terms of resources, and these are all available on the Cheshire and Merseyside Primary Care webpage. There's the urgent referral leaflet, which can be one of the resources used for patients at the point of referral. Further information about the National Cancer Diagnosis Audit, which is a useful tool for identifying current practice and a tool for reviewing cases. There's the nice interactive desk easel, which provides further information about their guidance and its application. There's the learning event template, which was previously the SEAs, which can provide that format for shared learning and quality improvement. There's also links to the Macmillan Top 10 Tips, which includes some summaries, particularly a single-page safety netting summary, and a whole range of other Macmillan resources that are available to support safety netting. There'll also on the webpage be details of your local Macmillan GP and CRUK facilitator, and the CRUK facilitator may have access to other resources such as referral log, which can be helpful within these processes. Be a link there as well to information about the primary care network level data for early diagnosis and screening, which is now available via the Public Health England Fingertips website, and also the safety netting toolkit that I'd previously mentioned, which includes these templates and searches, as well as training guides and videos for implementation. And that's been designed to meet all the criteria that we've just discussed, but also to be used for non-cancer other urgent referrals, with the aim being that can avoid duplication of different safety netting processes for different conditions, potentially. So hopefully that gives an overview of some of the safety netting knowledge, guidance and available resources and support that can help practices and primary care networks with safety netting, which in turn can help with the NHS long-term plan of improving care outcomes by early stage cancer diagnosis, and also help with our patient experience. So all those resources are available on the website, and thank you.